Hey everyone, thanks for joining us. So we are ROVER. We've got a presentation about sarcoma malignancies today. We've got three great faculty and physicians helping us with this. We've got Dr. Grace Blitzer from the University of Wisconsin, Dr. Amina Beatty, she's from the Medical College of Wisconsin, and we got Dr. Shauna Campbell from Cleveland Clinic. And then I am Caitlin Ragland. I'm a PGY4 at UAB. So we'll be covering some extremity sarcoma, non-oncologic resection of extremity sarcoma, and then a retroperitoneal sarcoma. So we've got some poll questions, and we'll have a little bit of time for questions along the way. Okay. Get
Alrighty.
started with extremity sarcoma.
Excellent. So I'm Dr. Grace Blitzer. My case is going to have a 40-year-old gentleman who presents with a left thigh mass. He had a dirt bike accident a couple months ago and said, my thigh's been hurting for a little bit, and then noticed a mass that was rapidly growing. When you see him in your clinic with an exam, there's some tenderness to palpation. This mass is non-mobile, but otherwise his strength is 5 out of 5. There's no neurological deficits and no inguinal lymph nodes that are palpable. And next slide. And so for sarcomas, of course, likely he would have gotten a CT first, maybe an ultrasound of the mass. But for us, we're going to cut to the best imaging, which is MRI. So here on screen left, you can see a T1 plus contrast MRI showing this heterogeneous mass with areas of kind of necrosis. And then on the right, you can see the T2 image with some edema, peritumoral edema. And we'll talk a little bit about why that's important in the future in our upcoming slides. Next slide, please. And then this is just showing you for sarcomas, anatomy is everything. Back from our M1 years, this is where it really comes into play. So for sarcomas, we need to be thinking about our compartments in limb sarcomas. So for this is a thigh, and we're looking at this. There's anterior, medial, and posterior compartments with various muscles in each. This gentleman's sarcoma is in his anterior compartment of his thigh. And that's important because between these compartments, there is fascia, which can help us form our CTV volumes. Next slide. And then again, this is just describing why anatomy is so important, in part because the natural history of soft tissue sarcomas is there's local invasion, but again, along anatomic planes. So it can grow longitudinally along those muscle fibers. It can track along neurovascular bundles or along fascial planes, but in general, we do not think of sarcoma as, it is more often contained in fascial planes, so growing kind of soup inf rather than radially through the fascia of the compartment. With the caveat, if you see that on imaging, believe it. But next slide. This is just briefly going over, so sarcomas, we think of them, they are predominantly extremity sarcomas. So about 2/3 of all your sarcomas are going to be extremity. That's why myself and Dr. Beatty will be doing, well, I guess I don't know what her case is, but I'm guessing it's an extremity. And then, the majority of our extremity sarcomas are in the lower extremity. Next slide. And so poll question 1. How in the world, this patient walks in, you see that MRI, it looks concerning, right? That is not a normal mass. How would we get a biopsy? Excellent. Yes. So great for everybody. Exactly right. We would not get an FNA. That is not the right choice for sarcomas. Core needle biopsy is preferred. Sometimes if are unable to get a core needle, we can think about excision, but excisional biopsy is something you should be very, very thoughtful. It needs to be quite small, and ideally it should be done by the oncologic surgeon who, would need to be doing more later. So core needle biopsy would be the best choice. If that is not feasible, then an incisional biopsy would likely be better than an excision of this big mass. Excellent. Next slide. So pathology here shows that it is undifferentiated pleomorphic sarcoma, grade 3. And then thinking about staging, you need to know, grading is very important for sarcomas because size matters, but then grade plays a big factor here in our staging and in our thinking for this. And I think there's something else on this slide, but Caitlin, correct me if I'm wrong. There you go. This just briefly shows it. This is the FNCLCC grade. On your written boards, you may be asked about this. So some of the scores go from 1 to 3, and then the tumor necrosis goes from 0 to 2. And all of these are added up to give you that grade. Next slide. And so how would you stage this? This is not a real question, just to show you. This was less than 10 centimeters, so it becomes a T, but greater than 5, so T2. Then it's that grade 3, so then that bumps us right into stage 3A. And then those lower bullet points are just to remind you that for sarcomas, node, it's just 0 or 1. It's binary. Are there nodes or not? And if there are, that in general is quite bad. Next slide. So we just said lymph nodes are bad. What is the risk? What is your risk if you have an extremity sarcoma of having lymph node involvement? All righty, got a nice spread. No one said 60 to 80, which is great. The majority did think less than 10%, which is exactly correct. Caitlin, I'll have you. Yep, perfect. So sarcomas in general do not spread to lymph nodes. That's why that staging system is binary. That being said, next slide, there are a few things that you will need to know of. Everyone likes to ask you about these. So some of these sarcoma histologies do like to spread to lymph nodes. The Kerr mnemonic is one way to look at it. Clear cell, angiosarc, rhabdomyosarcoma, and epithelioid. Sarcomas, something I don't have in the slides, but just for everyone to think about is we group this, 100 different histologies in one umbrella of sarcoma. So there is a lot of variation and heterogeneity despite calling this all soft tissue sarcoma and, telling you one way of treating this. But, this guy had undifferentiated pleomorphic sarcoma, which is a pretty common type and does not go to lymph nodes in general. Next slide. And then my final question is, where's the most common location for metastases in our extremity sarcomas? When you're thinking about, this is a grade 3 gentleman, so when you're thinking about scanning him, either for staging, and then in our follow-up, as we hope we have cured him, where is your surveillance imaging going to be? Do we need to get an MRI brain? Okay, excellent. That's exactly right. The vast majority said lungs, and that is exactly correct. In general, the most common for most sarcomas is lungs. That being said, NCCN, if you're ever treating a sarcoma, look on NCCN. There's a beautiful table summarizing certain histologies, you have to worry about going to the spine or going to other places. But in general, it's lungs. And then high-grade sarcomas, like this gentleman's, there's a rough rule of thumb. So he had a high-grade sarcoma that, let's say, was 8 centimeters. So you 4% times 8. So he has about a 1/3 chance of this metastasizing in the next 5 years. It's a rough rule of thumb, but something to keep in mind. All righty, next slide. So our initial workup, we talked about, you of course would need to get a CT chest to look for lung mets, but then also abdomen, pelvis, evaluating, are there any inguinal lymph nodes, anything else concerning, oh, there you go, I just said it, the NCCN guidelines. So for that myxoid or round cell liposarcoma, think about an MRI spine. Angiosarc can give you CNS metastases, so MRI brain, that sort of thing. Next slide. And then you're getting those labs showing nothing concerning. Yep, plan for treatment. Oh no, that's fine. There is nothing in there. Plan for treatment for this gentleman. So we just said use a T2N0, grade 3, so stage 3 liposarcoma that is resectable. It abuts the neurovascular bundle. It's in the proximal thigh, the anterior compartment. So your kind of options are, radiation and surgery. We, for sarcoma, the gold standard basically always is surgery if we can do it. And then we add in radiation because of very old data where we think about radiation plus surgery gives local control that is equivalent to doing amputation, and particularly in a proximal thigh. Amputation is not a good option. So we're thinking about adding radiation. So the question is, when do we add radiation? Do we add it in before or after treatment, after surgery? I apologize. And in general, before surgery is favored. Next slide. So NCCN has a beautiful discussion on this, and we all know this, but just to review it. So why do we favor pre-op radiation versus post-op? So pre-op, you can have smaller field sizes with a better delineation because you have that MRI of gross disease. You can use a lower radiation dose. Radiobiologically, you are treating oxygenated tumor. So all of these things add up. And then the disadvantage is there is some increased acute wound healing problems, we'll look at this in the next slide, but the kind of big Canadian study that looked at this did show worse wound healing acutely, which makes sense, right? If you're doing neoadjuvant radiation versus adjuvant, you'll have a little bit more wound complications. But long-term, folks do better, and we'll go over all that data. So thinking about surgery and adjuvant or postoperative radiation, the advantage is you know what you're getting into. We've done that surgery and we can know, exactly what type. Every once in a while, right, your biopsy is not concordant with the final path. You might know where the positive margin is or other things. There's no delay for surgery. If your patient is severely symptomatic and you make them go through 5 weeks of radiation, the sarcoma can get more and more symptomatic. And every once in a while, you might eliminate the need for radiation. T1s, so small extremity sarcomas may not need radiation. But the biggest disadvantage is that late fibrosis, late joint stiffness edema that is significantly higher with the postoperative versus preoperative radiation. And then, of course, larger field size, higher dose. So the dosing, 50 gray for preoperative versus 60 to 66 or 70 gray for postoperative. And it showed no difference in local control, but overall survival. But the difference that really I want to highlight again is the late, so acutely, pre-op is worse, but in the long run, patients do better with pre-op versus post-op. And then briefly, treatment, just to do my due diligence. Surgery, you always want a wide local excision. Don't shell it out. Try and get this all in one excellent oncologic surgery, and you want big margins for sarcomas. Next slide. Again, this is a good paper to know, just looking at the wound complications, shows that pre-op is worse than post-op. Predictors, so some of them size, some of them make sense, right? Size, yes, of course. But then also lower extremity has an increased risk for wound healing and wound complications versus upper extremity. Next slide. And then finally, I wanted to briefly go over contouring. So your gross tumor volume would be that MRI, the T1C, is where you can really see things well. And then your CTV is defined, 0630, RTOG 0630 gave us, it's a phase 2, but for sarcomas, that's almost as good as we can get. But it looked at preoperative radiation using CTV volumes of about 3 centimeters longitudinally, so along the muscle plane, and then 1.5 centimeters radially. And this was for high-grade tumors that were 8 centimeters or larger. And then if you had a smaller tumor, you could think about 2 cm and 1 cm. And then, of course, daily image guidance. Alrighty, and then the CTV, the other thing I wanted to include for contouring for that is think about, it should be confined by the compartment. So you do your expansions, your 3 and 1.5 cms. And then if you're going into bone, you shave back. If you have an anterior compartment sarcoma, and then that CTV expansion gets you into the posterior compartment, shave that off. And then you want to include the T2 edema shown on your MRI. Next slide. And then briefly including these, they have nice kind of images of this. This is both from our 2021 Astro Guidelines as well as a 2012 critical review. Next slide. And then because this is an important thing when you're out in practice on your own, CT simulation, it is worth going to. I'm sure everyone's attending, tell them to go, but truly for this, you really care about immobilization. You want a custom mold that ideally you're encompassing the joints above and below, right? So you want to get the ankle, the knee, the hip for that thigh to account for flexion, for extension, for rotation. All of these things really matter or else things will not align well. And then again, watching that, thinking about IV contrast, you want to, if possible, and this is a good kind of thinking about institutional practices differing, MRI in the treatment position. We try and do that, in their mold. We go right from our CT sim to a MR scanner on the same, in our department. And then thinking about scrotal shields, I just threw that in there because he's 40. Maybe he has 4 kids but wants another 4. So we're thinking about for thighs of, is it necessary and do I need to do that? And then of course, daily image guidance. We use Align RT. You can think, and of course, cone beam CTs, that's that image guidance, but also, tattoos, 3-point tattoos to help with the joint flexion and everything else. Next slide. Here's a picture, kind of standard radiation, that dose wash prescribed to 50 gray. Next slide. Briefly going over the constraints. The important things here, skin strip. There is no consensus definition for this. You want to make sure that you are getting, kind of skin, obviously, but then think about that subcute tissue where your lymphatics may be draining. You want it to be continuous along there. You want at least 2 cm of this. And the goal would be D max less than 20 gray, but if you have to, you can do the volume gain 20 gray, less than 50% of that skin strip. Then, of course, we have our joints and our bone, and there are all these different kind of constraints to think about. The goal with the bone would be to prevent, a longer term, a fracture from your radiation. And the other thing to think about is there has to be periosteal stripping or other surgical manipulation. That bone is going to be more prone for fracture anyways. Next slide. I think I'm already a little bit over time, so I'll go quickly. Complications to think about. This is based on our most modern, or at least more modern trials, RTOG 0630 and the O'Sullivan. These were both image-guided modern technique trials. Acute wound healing, probably about a third. Those are complications. And then late fibrosis. Edema is about 10%. Late joint stiffness is probably about 5%. So not huge, but something to think about. And that picture just shows a person with, you can see that visible edema, visible, the left lower extremity is larger than the right. So something, again, some of your patients, 10% may have this. Next slide. Very quickly, post-operative versus preoperative, what would you do? Thinking about dosing being higher, the volumes have to be larger because it's not GTV anymore, it's the post-op bed. Next slide. Positive margin. So what if you come across this, right? I just gave you this beautiful talk on neoadjuvant radiation. Surgeon comes back and says, I did my best, but it was along the neurovascular bundle and there is tumor left on the femoral nerve. What would you do? Next slide. Boost is pretty controversial. You can think about giving 16 gray, so getting up to 66, but there are these studies that didn't show improvement in local control with a postoperative boost. There's a lot of caveats. There's some nice letters to the editor, kind of fighting about this. But one thing that you can use to say, I may not need to do that to worry and boost the positive margin. There's a nice study from O'Donnell that looked at negative margins when you resected critical structures versus kind of R1 positive margin when you knew that was there and were treating that with radiation, didn't improve the local regional failure much. So meaning resecting a femoral nerve because of an R1 probably doesn't buy much. And we can worry a little bit less about that positive margin. So something to think about. If you do not have to knee-jerk, positive margin means boost. But there's nuances there. Next slide. Last and not least, your patient doesn't want to come in for 5 weeks. What do? There is a growing body of data looking at 5 fractions. There was a nice meta-analysis of this. These are all a single institution, but we're working on thinking about a randomized clinical trial. And I think that is it for me. I will stop talking and let the next excellent sarcoma expert go.
Thanks, Dr. Blitzer. That was a great overview. And I'll touch on some of those points as well, just in relation to your talk. But my section is to talk about these non-oncologically excised sarcomas. So Dr. Blitzer mentioned, you really want to get an oncologic resection, wide margins, but sometimes things are not as they appear. And this is kind of the topic that we're going to discuss next. Caitlin, can you advance? And then can you advance all of the, those components. So I have two cases. The first is a 6-year-old female presented to her PCP, enlarging right calf mass. Ultrasound showed about a 3 to 4 centimeter solid mass with vascularity. And then MRI confirmed that there was about a 3 centimeter mass in the medial aspect of the soleus muscle. Core biopsy was obtained, and it revealed an undifferentiated high-grade sarcoma with no distant disease. Patient B is very similar to patient A, 56-year-old male, left calf mass, about 3 centimeters on ultrasound with associated vascularity, but had an excisional biopsy. Again, the path similar to patient A was an undifferentiated high-grade sarcoma. Next slide, please. So we have, as I mentioned before, very similar cases, but one very big difference. And the question is, does this difference in the initial management affect outcomes? And so we'll chat about that a little bit later at the end of the slide deck. Next slide, please. So that's gets us to our first poll question. What is the incidence of non-oncologic resections in soft tissue sarcomas? Yeah, good array of answers. And this is hard to delineate. If you can go to the next slide. So oncologic resections, like Dr. Blitzer had mentioned, that's the mainstay of treatment. You want to have somebody who knows how to take out these tumors, take into consideration radiation, whether or not chemotherapy should be employed, and really have excellent rates of local control and survival. However, non-oncologic resections can occur about 18 to 65% of the time. So it's higher than a lot of us think that these non-oncologic resections occur quite often, and we've been seeing them more and more. And it's just, the term a non-oncologic resection are these unplanned excisions or resections without really considering those surgical margins, those wide surgical margins that we need to impact the control of the disease. Although about 20% or more have non-oncologic resections, only up to half are referred to tertiary centers for oncologic management. So, this is a rare disease. It's so heterogeneous. Having kind of the expertise in terms of delineating what to do next and how to do it, and just going through the thought process is oftentimes advantageous. Next slide. So unplanned excisions can definitely also have unplanned challenges. If you have gross or microscopic disease, those positive margins can increase the risk of local recurrence. Resections are often done piecemeal. The drains are not ideally positioned. Maybe they're really far away from the initial scar. You could have contamination of the adjacent compartments. The location of the primary tumor oftentimes details or plays into if it's a piecemeal, if there's going to be contamination, or where do you put the drains. Oftentimes you'll have post-operative seromas or hematomas, which can harbor microscopic cells. And then there's certainly also an economic impact to these unplanned excisions. If you can go to the next slide. So this was a publication, I think it was in 2020. This came out, next slide. And it determined, what is really the cost of care of these non-oncologic resections? And it showed that there was an increased length of hospital stay, 18 days versus 12 days, increased number of surgeries, 2+ surgeries that patients who had unplanned excisions underwent, and 64% higher cost with these unplanned excisions. So really there is a lot of challenges, not just from a clinical standpoint, but economic and healthcare wise. Next slide. So how do we manage soft tissue, a non-oncologic resection? So as I mentioned before, up to about 50% are referred to tertiary centers. And I think it's so important to have a center that has a really strong multidisciplinary team, surgical, oncology, rad-onc, med-onc, radiology, plastics, pathology. All of the input is really important in determining kind of next steps. Factors include you want to take into consideration the imaging, what's the histology, how do they excise it, what did they use, did they use lidocaine, was it an in-office excision and they used lidocaine, and that wheel around the lidocaine was something that harbored malignant cells. What was a surgeon experience? Again, location. And the management is going to be variable depending on all of these factors. If you could go to the next slide. So this is a great slide from the consensus guidelines, as published in 2021. And it briefly went over unplanned excisions and local management after an unplanned excision. And if you look through this flow sheet, a lot of it is dictated by the risk of local recurrence, but really, can you re-excise these non-oncologic resections? Next slide. So if you have and are able to, oncologic re-excision is recommended if it's technically feasible. If you're going to have some morbidity, like removing the femoral nerve or any of these other structures, like Dr. Blitzer had mentioned, then it might be more morbid than the benefit you'll get out of it. But I think it's worth being a little bit more aggressive, given that these are unplanned excisions. Will they have acceptable morbidity? Can we remove the residual disease and the contaminated tissue? Next slide, please. So that brings us to our second question of this block. What is the incidence of residual disease in patients who undergo re-resection after non-oncologic resection in soft tissue sarcomas? Good. Yeah, again, an array of answers, but next slide. But if you look at the data, over 20% of soft tissue sarcoma, non-oncologic resection soft tissue sarcomas will have residual tumor, whether it's microscopic, rarely gross residual disease. Most times it's microscopic. Outcomes, the question is, does that affect disease-specific and overall survival? Does that affect local control? Does that affect morbidity? We talked about, the local control and morbidity and cost of care are all impacted. Next slide. But this study, this was published just recently, I think within the last year, that showed that residual disease at re-excision was associated with a higher risk of local recurrence at 5 years. And local recurrence at 5 years was associated with worse survival. So if you had a local recurrence, your 5-year overall survival was poorer compared to someone who had an oncologic resection. If you could go to the next slide. So just like Dr. Blitzer had mentioned, how do we manage these? We talked about preoperative radiation in the last block. You certainly could entertain quote unquote preoperative radiation followed by re-resection. You would just do your standard 50 gray, 2 gray per fraction. Postoperative radiation to 60 to 66. If there's positive margins, you try to get close to 66, particularly if it's diffuse positive margins. But again, you have to take in, when you're planning your radiation, you have to really take into consideration, did they use lidocaine? What was the instrumentation? Did they violate the adjacent compartments? I had one case where they presumed the patient had a lipoma of the bicep and a lipoma of the thigh. They resected the thigh lipoma, and then with the same instrument went in and resected the arm, the arm lipoma. And the arm was a lipoma, but the thigh was a sarcoma. And on subsequent imaging, the patient developed a sarcoma in the right upper extremity. So it's really trying to understand and reading that operative report, talking to the surgeons to just try and gauge kind of what went on and how that will dictate how you manage that from a radiation perspective as well. Next slide. So this is just a case within the cases, the earlier cases, but I just recently had a 46-year-old male. He had a presumed 16-centimeter lipoma of the thigh, like medial compartment thigh. An MRI was obtained, interestingly, before the resection. It did not look like a lipoma, but they excised it like a lipoma. And lo and behold, this patient had multiple positive margins. There's a large scar extending to the groin. The drain was like 5 or 6 centimeters away. There was multiple positive, as I mentioned, diffuse positive margins. And so again, going into the tumor board, having this discussion with the surgeons and looking at the operative report, looking at the histology, this was a low grade, ended up being a low grade myxoid liposarcoma. We could have recommended preoperative radiation, re-resection followed by post-op RT, or, some people could observe, although with the positive margins that were diffuse, I would less favor that. And so what we decided was, if you can go down to the next slide, re-resection followed by postoperative radiation. So typically I'll try and recommend pre-op radiation followed by re-resection because it's a lower dose. You can try and get a smaller field size, but the caveat with this is depending on where it's located, depending on if they contaminated adjacent compartments, your volumes are quite big, no matter if it's pre-op or post-op. And pre-op for sure, you give 50 gray and they re-excise. But the reason we did post-op RT, re-resection than post-op RT, was the incision was large, it looked irregular, the drain site was further away. And thankfully, which was really interesting, the path revealed no residual disease, even though they had multiple positive margins. So what I did was we obtained an MRI post-op, but we did post-operative radiation, and I used the consensus guidelines to help me guide my treatment. But again, guide and not really finalize my treatment because I had to take into consideration, did this person have contamination or whatever? As Dr. Blitzer had mentioned, CT simulation is very important because the positioning is key. So in this setting, I put the patient in a frog-leg position in back fix. I marked the drain sites. I wired a scar. I displaced his scrotum to the contralateral side as much as I could. He was 46, and we had a long discussion about fertility, and he wasn't interested in preserving fertility because he certainly was going to be infertile after I treated him because of just the proximity. So, but that's, we'll talk about that, but that's something very important. If you go to the next slide. Okay, 3D versus IMRT. Usually in the thigh, I will try, and in many locations, I will really try to do IMRT. It gives you a nice conformal dose. You're not going into these adjacent compartments and affecting some of that from a toxicity standpoint. But as I mentioned before, we talked about the operative report. In this case, it looked like the patient had violated, the initial surgeon had violated other compartments. So I didn't follow that standard cut through, the fascial component as your CTV because the other compartments were violated in the resection. So it's important for me so that you can see the field is really, really large. And I had a PTV1 that went to 50 gray, which was the operative bed, plus a 1.5 centimeter radial margin, but I didn't crop it out of the adjacent compartments. And then 3 to 4 centimeters sup inf. And then PTV2 was a boost down to the operative bed plus a truncated margin, still 1.5 centimeters radial, but only 2 centimeters sup and inf. And I'll just be really honest, those don't really look very different. So it's like you're just giving almost everything 60 gray, but it is, attempt to really just focus the radiation on the area that was at the highest risk of recurrence. Side effects are really important, particularly when you're doing a 3D plan in the medial thigh. You certainly are going to get moist desquamation in the inguinal fold and scrotal area, in the perianal area. So having management and supportive therapies to manage this is important. Long-term side effects, infertility, as I mentioned before. So it's really important to counsel patients. Do you want to freeze your sperm, or how do you want to go about that? Avascular necrosis of the femoral head. You can see that some of that dose went into the femoral head, and not necessarily in the acetabulum, but you could have avascular necrosis. You can have an insufficiency fracture. It's about 10 to 15% risk of an insufficiency fracture. Particularly if you can't make your margins. If you're in the pelvis, it's about 10 to 15%, even if you can make your margins. And then scar tissue. It's certainly, surgery can cause scar tissue, but radiation does not help the scar tissue situation. And Dr. Blitzer talked about postoperative radiation, how you have a higher risk of like joint stiffness. So it's really important to try and contour the joints. So in this setting, I did the hip and then the knee, even though it didn't really go close to the knee, just to ensure that I was giving we were meeting the constraints. Next slide, please. So back to our tale. So the first patient referred to a tertiary sarcoma center after they had the core needle biopsy, underwent preoperative radiation, path revealed high-grade sarcoma with some treatment effect. Margins were negative, did routine scans. Today, she's alive and well. Patient B, if you can there. So underwent re-excision after the initial unplanned resection, had positive margins. So then went to the tertiary sarcoma center and underwent an oncologic re-resection. Path revealed a residual high-grade sarcoma with treatment effect. This patient did get preoperative radiation as well, preoperative, quote unquote. Margins were negative. Surveillance scans revealed metastatic disease, unfortunately, 1 year later, received multiple lines of systemic therapy, and then passed away about 5 years after their initial diagnosis. So if you can go next, thank you. So just in summary, non-oncologic resections can be common, up to even 65% of cases, depending on where you live and, what resources you have. But consequences, it's higher costs, more surgeries, local hospital stays, increased risks of local recurrence. Residual disease is common after unplanned excisions, and it can lead to worsened outcomes, particularly recurrence and survival can be impacted. Multidisciplinary evaluation is important. It's probably the most important thing, to have a thoughtful conversation about what the recommendations can be and should be. And then radiation and oncologic re-excision can salvage some outcomes, but they really don't fully mitigate the initial management of the non-oncologic resections. It's hard to get down to that less than 5% local control rate from a preoperative or any type of radiation added with a re-excision. So it's really important that early diagnosis, you properly biopsy and coordinate care are optimal and very important for our optimal outcomes. Thank you.
Excellent, thank you. We've got our final presentation of retroperitoneal sarcoma.
All right, thanks everyone. Thanks for being with us this afternoon and those who will join later online. So I'm Shauna Campbell. I will be talking about retroperitoneal sarcoma. So a little bit that's maybe not quite as cut and dry as it is in the extremity realm. You go to the next slide. So what we're going to talk about today is the case of a 72-year-old man who presented with progressive back pain, dyspepsia, and increasing abdominal girth. He also had about a 15-pound weight loss associated in the last 2 months. Past medical history, he does have diabetes, history of a DVT, unprovoked, unknown cause. That was 2 years prior. And also iron deficiency anemia found on recent labs. On physical exam, he's got a significantly distended abdomen, almost like the pregnant-looking abdomen that we can see in some men. Firm, no significant tenderness, no other pertinent findings. Next slide. And so he undergoes a CT scan with contrast as pictured here on the left. And what we can see is this large heterogeneous mass sort of originating what appears to be from the right abdomen with significant displacement upwards on the liver, leftwards on all of this bowel, just significant displacement. And you can see there is a solid component of this tumor, as well as you can see a lot of like stranding fat surrounding it as well. On his baseline labs, we can see that he does have an elevated creatinine of 1.83 with a decreased GFR of 38. Otherwise, his labs are not too significantly off, and he does have just that little bit of anemia with a hemoglobin of 11. Next slide. So he underwent a CT-guided biopsy, and this demonstrated atypical spindle cell proliferation with necrosis. So within sarcoma land, it's not uncommon. We see these very broad, general sort of pathology reads, especially if you're getting something from a center that doesn't have as much experience reviewing soft tissue sarcoma pathology. So then for our first poll question on the retroperitoneal case, we're going to say, so based on this pathology report that we have here, what is going to be the recommendation for our next steps? I want you to consider, is this a cancer? Is this consistent with our imaging? So we'll just select from the options here. All right, so we have 54% of people reported repeat biopsy and 46% of people said, let's just go right to surgery. So in this situation, my recommendation would be a repeat biopsy. So I think we're all on the same page that we know there's something very suspicious here going on. But my recommendation, especially as a radiation oncologist, if you're a surgeon, if there's any surgeons on the phone, they're going to say, I know this is a cancer. I'm going to go right to the operating room and take it out. I know what needs to come out. But as a radiation oncologist, we always want to be thinking, do we have a role in this? And so it's always best to get a repeat biopsy to know exactly what you're dealing with to help us all make the best decisions. So he has a repeat CT-guided biopsy, and this demonstrated the now definitive but still somewhat general diagnosis of a malignant spindle cell neoplasm. Now, further testing was done on this. So we can see here listed moderate to severe nuclear atypia. We've got our IHC stains here that have been completed. And we have something additional, an MDM2 gene amplification by FISH. So let's go to the next question. And so what sarcoma is an MDM2 amplification diagnostic of? This is a bit of a hard question, but this is a really important one. Because when you get these general pathologies, just a malignant spindle cell neoplasm, you really want to be asking your pathologist, what else can we be looking at? You know, is there more specific? Sometimes there's not, but oftentimes there is. And so an MDM2 amplification is going to be diagnostic of a liposarcoma. Okay, so that's a really important diagnostic feature. They can really help the pathologist that microscopically they can't really tell, but that doing this gene amplification by FISH is very helpful. We'll go to the next slide. Okay, so for final pathology from biopsy, we have a 72-year-old gentleman with a well-differentiated liposarcoma. You want a complete staging for this, okay? So this is well differentiated, and as Dr. Blitzer had mentioned earlier, you always want to question is there always a potential sampling error? So this is well differentiated, but looking at that tumor, I'm thinking in my head with that much solid component, is there a dedifferentiated component of it? So we get a CT chest just to be sure before we put him under some drastic surgery, and there's no evidence of distant metastasis on it. So here's the staging for retroperitoneal sarcoma. So very similar numbers as we see in sarcoma land. This patient does have a clinical T4N0M0 retroperitoneal sarcoma. We'll go to the next slide. And for our next question, so for patients with newly diagnosed localized retroperitoneal sarcoma, who do you consider preoperative radiation for? And this is looking at discussing it based on histologies. So do we do it on leiomyosarcomas, liposarcomas, malignant spindle cell, or do we do it on everybody? All right, so we've got 44% of people vote for liposarcoma and 56% of people say all histologies. So let's go to the next study, the next slide, which is going to detail the clinical trial of the STRASS trial. Okay, so the STRASS trial, this was a very important, very big, this is an excellent study that was done. It was a phase 3 study of 266 patients that were randomized to surgery, so right to surgery versus surgery with preoperative radiation of 50.4 gray and 28 fractions. This was retroperitoneal sarcoma, so this included liposarcoma, leiomyosarcoma, and other histologies. And the primary endpoint was evaluating if the addition of preoperative radiation improved abdominal recurrence-free survival. Now, this is a combined endpoint. It's a little bit of a complicated endpoint that you can see here. All of these factors would lead to a sort of, a potential failure or a potential event. So if somebody was to have a local or distant progressive disease during preoperative radiation, we would consider that an event in the preoperative radiation. If patient became inoperable, if they developed peritoneal metastasis found at surgery, if you had microscopic residual disease left in that surgery, or you experienced a local relapse. So this is a complicated endpoint, which when you look at it and knowing the results of the trial, we go, well, no wonder the trial was, well, I don't want to ruin it, but was originally negative. Is look at all of the things that we blamed, if this happened, radiation was deemed not beneficial. So this study was reported with a median of 43 months of follow-up, and 75% of these patients were liposarcoma patients. We'll go to the next slide. And so overall, with the primary endpoint, as discussed in the last slide, what we found is there was not a significant improvement in abdominal recurrence-free survival with the addition of preoperative radiation to surgery in retroperitoneal sarcomas. So we can see that these were not significantly different, these numbers there. However, what you know is that this combined endpoint did not account for those patients. So patient could have been deemed a progression. However, they still went to surgery. So then you're really questioning, is that actually an event? If a patient went to surgery and had a gross total resection, an R0, R1 resection, do we really consider that a failure? And the answer should be no. So then there were 2 sensitivity analyses that were completed. The first one was deemed for the patient was not deemed to have an event of local progression. If after radiation they were still able to go to surgery and undergo an R0 or R1 resection. Additionally, there was a second sensitivity analysis that if there was local progression or they became medically unfit by criteria, but were still actually able to go to surgery and undergo a resection, a complete resection. So this is what we did these sensitivity analyses for. And we'll go to the next slide. So for the first sensitivity analysis, these are the numbers that we look at when you do it. And these are looking at the liposarcoma patients only. So as we mentioned, 266 patient studies, 75% of these were liposarcomas. So when you look at this subgroup, which again, I acknowledge this study was not designed to only look, these are post hoc analyses, but we have this beautiful randomized trial that we really need to try and understand. So what we found that local recurrence was 59% in the surgery group versus 41% in the radiation plus surgery group. And this led to an abdominal recurrence-free survival at 3 years of 60% versus 71.6%. You can see the confidence interval, so hazard ratio of 0.64. Your confidence interval is going to just barely crossing 1, but still these numbers numerically and overall look very favorable. Then when you look at the second sensitivity analysis, we see local recurrence 60% versus 40% with the addition of radiation. So we're seeing here about a 20% decrease in the local recurrence. And then looking at the abdominal recurrence-free survival, we've got 65% versus 75%. So again, overall, what we're looking at here, we are seeing that there might actually be a subgroup of patients that are benefiting. On the next slide. So the conclusion of this study is preoperative radiation does not improve abdominal recurrence-free survival or overall survival in this whole study population. For those of us who want to look at these details, these fine details, which tend to be radiation oncologists, and try and really understand this, and what we see is that in these post-hoc analyses that the liposarcoma histology patients, preoperative radiation is going to result in about a 50% reduction in the rate of local failure and about a 10% absolute decrease in the abdominal recurrence-free survival. So overall, we do think there is a benefit in certain patients, certain of these patients. We can go to the next slide. So just to go back to our case that we talked about, this was a patient that I actually treated with preoperative radiation. I did 50.4 gray in 25 fractions. The Strass contouring is going to be your GTV. And the thing with retroperitoneal sarcomas is you want to be cognizant of that solid component, which is really easy to see. But there's also a lot of fatty stranding and haziness that also usually correlates with liposarcoma. So it was a CTV 5 millimeters per Strass, and then you can see this asymmetric PTV expansion. Again, you really have to acknowledge in these tumors, there's a lot of normal structures that are really close by. So you want to be very cognizant when you're drawing your CTV that you're not going into the bowel, because this is a good situation. I learned a lot from my surgeons and understanding that these tumors, while the posterior wall, the psoas, that sort of thing, it really sticks to these areas. When it comes to the bowel, it's quite often just anteriorly displacing or pushing the bowel, usually comes off of the bowel really, really nicely. So that area maybe is not as high risk. You know, as radiation oncologists, we tend to think of 360 degrees as the same risk. When it comes to retroperitoneal sarcomas with all of this bowel, which tends to be our dose limiting structures, it actually, you know, that it challenges our thinking with that, and it's impacted how I draw some of my patients. Personally, I tend to draw 5 millimeter CTV, start with a 5 millimeter PTV, and again, adjust accordingly. I think sarcoma, there's a lot of art to the radiation in sarcoma and individualizing to each patient. I'm a really big believer in. Again, CTV, you start with 5 millimeters, but again, knowing supra-nymph, you know, into these recesses, you just really want to be critical because that's where patients recur, is in these kind of recesses around blood vessels and muscles and that sort of thing. You can go to the next slide. So post-operative radiation, you know, if our patient would have went right to surgery, he probably would have had a bunch of positive margins, and he would have come to us and said, what should we do? And I apologize, I didn't put a picture of this in. But for these patients, the bowel, everything, like you see how these tumors just nicely push the bowel and everything out of the way. There is still some dose to that bowel, but I promise you, it is drastically less in the preoperative setting than when you try and do postoperative radiation. I do not do really any postoperative radiation. These tend to be big tumors, and then you're left trying to understand what is actually at risk. Where are these positive margins? You know, my bowel dose ends up being a whole lot higher. It's just can be really toxic, and I kind of feel like we're chasing something that we can't see. So how I counsel patients if they come to me inquiring about postoperative radiation, I say, you know, we acknowledge we have a risk of recurrence, but right now I'd be treating a really big area. And, you know, I'm not sure where you're actually going to recur. So what I do is I say, we're going to save the radiation. And if you recur locally, we will use it preoperative at that time before the next surgery. Next slide. That might be it. Just to give a quick shout out for some unresectable retroperitoneal sarcomas. You know, we often see older people that are really sick and they might have 1 or 2 mets, or they might just have the primary tumor. This was a case on the left here that I treated early on in my career. This gentleman, the tumor was growing faster than we could keep track of. He was hemorrhaging into it, you know, recurrent anemia requiring transfusions, and there was no way in heaven this guy was going to get to any kind of chemotherapy with how he was. So I did in the top plane here, you can see a spatially fractionated radiation plan of, I think it was 18 gray in a single fraction. And then I followed him up with 30 gray in 10 fractions. And that's the plan that you can see a bit lower down there. Now, what was interesting about him is he did have a muscle deposit in the psoas. You can see here in the bottom right here, there was another deposit. So for me, when I first started this and, I did the spatially fractionated radiation, I was a little bit hesitant. Is it actually going to change anything? And this case made me a believer, because if you see here, the images on the right here were my pre-radiation. The images on the left are my post-radiation. Actually, sort of the top one there, the right is pre and the left is post. And then the bottom is flipped. And the reason I'm a big believer in spatially fractionated radiation is the primary tumor, which I did do the SFRT2 followed by 30 and 10, that shrank beautifully during treatment. When I scanned him, it was about 2 or 3 months later. That was the interval between these. That muscle deposit that I only did 30 and 10 to, and I didn't do SFRT2, that had actually grown. So that, that's everyone's sort of N of 1 that kind of makes you a believer. But with spatially fractionated radiation, it's something I try and incorporate for these patients that I know that 30 and 10 or even, just isn't going to be very satisfying. And what I do is when I make these plans, I do a maximum point dose to the normal structures of like 5 to 6 gray. And so you really contain your dose to normal structure. So you're really just kind of heating up, the center of the tumor. So that's my plug for unresectable retroperitoneal sarcomas, is just really try and think of, because the morbidity of this local tumor is incredible for these patients and will be a driver of death. Okay.
That's great. Does anyone have any kind of comments back and forth between thoughts? But otherwise, I think we should wrap up as we're at 3 o'clock, or 3 o'clock my time. Okay, it was great having you all. Thank you so much for all of those attending. This was our final 2024-25 session. We've got some great resident and medical student kind of specific sessions planned for next year. So we hope to see you then.